When palpating the back, we can use various bony landmarks to get us onto approximate vertebral levels and getting us onto spinous processes at different vertebral levels. So some of the most important ones that line up with different vertebral levels is, I'll start the first one, which is lumbar 4, which lines up with the iliac crest. So if I place my hand, sorry, ticklish? Sorry. So if you place your hands on the superior aspect of the iliac crest, and then if your thumbs meet directly in the, oops, you can see that, directly in the middle, in the midline, I'll show you this way. So the iliac crest is here. My thumb is coming around right into the midline of the body. So this is the spinous process of lumbar 4. If you can just bring your hands just by your side. Just comfortable. Yep. There you go. So we can palpate the inferior angle of the scapula, which is right here. If I draw a line directly medial towards the spine, I will be in line with the spinous process of thoracic 7. The other one that I'll show you is the spine of the scapula. So we can palpate the spine of the scapula, and from that region we can come directly medial, and directly in line with the spine of the scapula is thoracic 3. We've also learned one more landmark when we were palpating the bony landmarks of the pelvis, and so we looked at the PSIS was in line with sacral 2. So there's a number of bony landmarks that we can use to get us onto approximate levels of the spine, and then we can count spinous processes to get to different levels. Cervical 7 is also referred to as the vertebral prominence, and the reason for that is it's typically the most prominent spinous process, and we can palpate it at the neck. Sorry, they're cold. We can palpate it at the neck, and there could be the cervical 6 and thoracic 1 it might be hard to distinguish which is the most prominent. So there's ways that we can find that out by involving the patient to determine which level we're at. So what you're going to do is you're going to take your index finger, your middle finger, and your ring finger, and you're going to lay it on the patient's neck, close to sort of the base of the neck, in through an area where you feel like the spinous processes are sticking out quite a bit. So what I'm doing right now is I believe my middle finger is on cervical 7, which would mean my ring finger is on thoracic 1, and my index finger is on cervical 6. So to confirm that, what I can do is I can have my patient flex her head forward, so bring your chin to your chest. And when I do that, all 3 should be very prominent. When I ask my patient to extend her head, so can you bring your gaze towards the ceiling just slightly? Yeah, good, stop there. Okay, when my patient brings her gaze towards the ceiling, the spinous process of cervical 6 moves anterior and it's not palpable anymore. So if I'm on the correct area, I should not feel anything underneath my index finger any longer, and I should feel the most prominent or the next most prominent spinous process would then be cervical 7. If you still feel, you can just bring your head back to neutral. If you still feel like you can palpate a spinous process when the neck is in extension, you can adjust your hands slightly, move them up. So I'm going to do this. Okay, can you look up towards the ceiling one more time? Great. So now I cannot feel cervical 6 underneath my index finger. So now this I can confirm is cervical 7 underneath my middle finger. When palpating the spinous processes of the thoracolumbar spine, so in the thoracic region, we have 12 thoracic vertebrae, and we have 5 lumbar vertebrae. And each of the spinous processes of these vertebrae are palpable. The spinous processes of the thoracic spine are a little bit easier to palpate, and one of the primary reasons for that is the natural kyphotic curvature of the spine. So in the thoracic region, our spine naturally has a kyphotic curvature, and so that pushes or has the spinous processes stick out a little bit more posteriorly. When the spine changes regions, and now we get into the lumbar region, now we have a bit of a lordotic curvature, where it sort of curves. It's like a concave shape if we're looking at it from a posterior aspect. So this might be a little bit more challenging to find. They are the largest vertebrae. So if you're having trouble finding the spinous processes in the lumbar vertebrae, you can ask your patient to round their back. So they want to sort of bend forward enough that their lower back starts to bend. Is that comfortable? Are you okay?
Mm-hmm.
Okay. So now I can really feel the spinous processes in the lumbar region stick out a little bit more. Okay, go ahead and sit up. So if you are tackling a palpation in the thoracic spine or the lumbar spine on your practical test, it might say palpate the spinous process of thoracic 6. So you can use your landmarking to find a particular vertebral level, and then you can count up or down to your target level. So if I want to find thoracic 6, I also want to start 2 joints away. So I would start on the spine of the scapula. I would come directly medial onto thoracic 3. Then I will palpate each spinous process. So I'm just going to gently push in thoracic 3, thoracic 4, 5, and 6. Okay, and I'm on the spinous process of thoracic 6. I can also sort of do a visual landmark too. I know that the spinous process of thoracic 7 lines up with the inferior angle. So as long as I'm not below that in my palpation, I know I've not gone too far. So that would be the spinous process for thoracic 6. If you were given the find the spinous process of lumbar 1, you could start at the iliac crest, directly medial onto lumbar 4. Can I get you to round your back just a wee bit more? Like bend at your, yeah. Okay, so lumbar 4, lumbar 3, lumbar 2. So I've crossed over a number of joints. Each time you go to a new spinous process, you're on a new joint. And lumbar 1. Okay, good. Go ahead and sit back up. Okay, and so I'm on the spinous process of lumbar 1. To palpate the transverse processes of the thoracolumbar spine, in the lumbar spine, it's a little more straightforward. In the thoracic spine, it's a little bit more complex, but we'll go through it. So what's nice about the lumbar spine is that the spinous process is in direct alignment to the transverse process. So if I am palpating the spinous process, I can move directly lateral and I'm on the same vertebral level. So if I go onto the, reticulus, sorry, okay, you good?
Yep.
Okay, so if I go onto the spinous process of lumbar 4, if I come directly lateral, okay, I can apply a pressure, and if I apply a pressure to the transverse process, if I'm on the same vertebrae, then as I push on the transverse process, I will feel the spinous process underneath my other finger start to move. Okay, this would be more appropriately palpated in a prone position, but I'm showing you in seated so that you can have a better angle. So if you want to find the spinous processes or the transverse processes, definitely with the transverse processes, put them in a prone position so that you can apply that pressure to feel the movement of the spinous process. So if you get lumbar 1 through 5, you're going to landmark that spinous process, get to it, move directly lateral onto the transverse process, apply a pressure to the transverse process, and that's how you confirm. If as you push on the transverse process, you feel the spinous process move, then you are on the correct level. If you're applying a pressure and you don't feel that spinous process move, you might be on the spinous process of a different vertebral level. So you might just have to adjust your hands slightly. It gets a little more complicated in the thoracic spine, and the primary reason for that is that as we get more inferior in the thoracic spine, the angle of the spinous processes change. So when we learn the thoracic spine, we will talk about the rules of 3, and I'll explain what that means. There are 12 thoracic vertebrae, and we break them up into groupings of 3. Our first 3, thoracic 1, thoracic 2, thoracic 3, their spinous processes project directly posterior. So they stick straight backwards, which means that their transverse processes are directly lateral. These are some of the easier ones. So similar to the lumbar spine, if we go directly lateral, we can apply a pressure. Okay, we can push in and try to manipulate that transverse process. And if I'm on the correct vertebral level, I'll feel that spinous process start to move underneath my finger as I apply the pressure. In our next grouping of 3, which is thoracic 4, thoracic 5, and thoracic 6, that angle of the spinous process starts to change. So instead of projecting directly posterior, that spinous process actually starts to point down just slightly. What that means is when we are palpating the spinous process of thoracic 4, 5, or 6, the transverse process is not directly lateral, but it's located halfway between the spinous process above and the one that we're on. It's a half a vertebral level superior to the spinous process. So the way that we're going to find that, if my target is the transverse process of thoracic 6, I know that the spinous process is going to be slightly lower, a half a level lower. So here's what I'm going to do. I'm going to have one finger on thoracic 6, and I'm also going to place a second finger on the spinous process of thoracic 5. So I have these 2 vertebrae landmarked. What I'm going to do is take my second hand and I'm going to go halfway between thoracic 5 and thoracic 6 and just lateral. If I apply a pressure here, what I should feel is the spinous process of thoracic 6 moving underneath my finger if I'm on the correct vertebral level. So 4, 5, and 6, the transverse process is a half a level above where the spinous process is. Hopefully you're still with me. Our next grouping of 3 is thoracic 7, 8, and 9. And the angle, this is where the angle is most drastic. So it doesn't project straightly posterior. It doesn't project slightly down. It projects significantly down. And what that means is that the transverse process is a full vertebral level higher than our spinous process. So I can show you how to palpate the transverse process. Let's use the example of the transverse process of thoracic 9. So I'm going to start with palpating the inferior angle of the scapula. Coming directly medial, that puts me in line with the spinous process of thoracic 7. Then I can palpate inferiorly to thoracic 8 and inferiorly again to thoracic 9. So I know with my rules of 3 that the spinous process projects almost inferior. And so the transverse process is a full vertebral level above where that spinous process is. So if I want to find the transverse process of thoracic 9, I'm going to get onto the spinous process of thoracic 9 first. I'm going to palpate one vertebral level higher, one full level higher. So I have a finger on now the spinous process of thoracic 8. And I'm going to move directly lateral to the spinous process of thoracic 8. And I'm going to apply a pressure here. So you can see, hopefully, that if I apply a pressure here, this finger should feel movement underneath it from that spinous process. So it's a full vertebral level above. So I apply pressure here, I can feel that spinous process move. So our first 3 groupings, the first one, thoracic 1, 2, and 3, the spinous process projects directly posterior. Thoracic 4, 5, and 6, the angle starts to change slightly, which means the TVP, the transverse process, is a half a vertebral level above where you find the spinous process. Thoracic 7, 8, 9, the angle is quite significant, so the transverse process is a full vertebral level above where the spinous process is. When we get to our last grouping of 3, it moves in the reverse order and quite a bit quicker. So thoracic 10 looks very similar to the group that we just did. Thoracic 10 is a full vertebral level below. The spinous process is a full vertebral level below than the transverse process. Then the angle starts to change. So thoracic 11, it comes up about halfway. So my transverse process of thoracic 11 is half a vertebral level above my spinous process of thoracic 11. And then finally, when we get to thoracic 12, it has moved right back up and it projects directly posterior. So thoracic 12 looks really similar to thoracic 1, 2, and 3, where the transverse process is directly lateral. Okay, so knowing your rules of 3 will help you accurately find the transverse process relative to the spinous process. To palpate the laminar groove of the spine, we can move laterally off of the spinous processes and before we get to the transverse processes. So the laminar groove is in between the SPs and the TVPs. So let's say I said to palpate the laminar groove between thoracic 3 and thoracic 7. So you can start on so I'm going to palpate the iliac crest, lumbar 4. I'm going to work my way superiorly, so lumbar 3, lumbar 2, first lumbar vertebrae. Let me go to 12. I took a really long trail. 11, 10, 9, 8, and 7. And 7 should line up with that inferior angle. I also could have started on cervical 7, doing my confirmation and moving down that way. So the laminar groove between thoracic 3 and thoracic 7, thoracic 3 lines up with the spine of the scapula. So I'm going to move just lateral off that spinous process and I'm going to gently sort of push deep. And if I strum medial to lateral, my fingertips are in the laminar groove. We're going to palpate the Erector Spinae as a full group. So individually, the Erector Spinae, which is from lateral to medial, is iliocostalis, longissimus, and spinalis. We're going to palpate these as a group. They have quite a number of attachment points, but I'll show you how we can get there. So my starting point for the Erector Spinae group can be the patella. From the patella, I'm going to move on to the lateral femoral condyle, superiorly or proximally along the lateral aspect of the thigh until I get on to the iliac crest. I want to get onto the posterior part of the iliac crest. I'm going to trail it back behind. And this is one of the attachment points for the Erector Spinae, so I can start my cross-fiber palpation. So from here, the Erector Spinae run superior to inferior. So I'm going to cross-fiber along the Erector Spinae. They have attachment onto the ribs, They also have attachment onto the occiput and the mastoid process. So I will continue my cross-fiber palpation all the way up until I get to the occiput, and the mastoid process is just behind the ear. It's a bony prominence just behind the ear, and that's where I'd finish my palpation. The Erector Spinae group does extension of the back and extension of the neck. So what I'm going to do is I'm actually going to ask my patient to put her hands up on the table, just on the, like, put your hands on the table this way. Yep, and just do like a mini push up. So you want to like round your back. Yep, that's perfect. Good. And relax back down. The resistance for that is gravity. I could apply a resistance to my patient, but gravity is also working against them. I don't want to make it too hard for my patient. So when they're pushing up, that's the resisted action for the Erector Spinae. To palpate the Quadratus lumborum, we can start at the patella. We can move onto the lateral tibial condyle, and then proximally onto the lateral femoral condyle. We can trail proximally along the lateral aspect of the thigh until we get to the iliac crest. And if I'm in sort of the middle of the iliac crest, I want to come just posterior. And this is one of the attachment points for Quadratus lumborum. So quadratus refers to, it's like a square shape, and it's located in the lumbar region. So I can start my cross-fiber palpation here. The fibers of Quadratus lumborum run superior to inferior. So my cross-fiber palpation will be medial to lateral. The Quadratus lumborum is deep to the Erector Spinae. The Erector Spinae overlay. So Quadratus lumborum is deep, and then Erector's lay over top. So when you show your resisted action for this, you're going to ask your patient to do the same thing as the Erector Spinae. So they can put their hands up on the table. They can extend through the back. So Quadratus lumborum, when it acts bilaterally, it does extension of the lumbar spine. When it acts unilaterally, it does ipsilateral lateral flexion. So when our patient is on the table, it's easier to do extension of the back. So you would ask your patient to show the resisted action, then you would have them rest down and do your cross-fiber palpation then. If you're trying to cross-fiber while the patient is performing the resisted action, you have to press through the Erector Spinae, which would also be engaging because they also extend the spine when they work bilaterally. So have your patient rest down so that you can sink in through Erector Spinae and you can palpate Quadratus lumborum easier.